pleasure to be here with you this afternoon. I'm a pharmacist by training, so this is an issue that I view as very important. You need to look no further than the daily headlines to know that we are in the middle of a health care crisis. And I don't need to tell you this because as practitioners on the front line of patient care, you see this every day. The solution to this problem is not easy, and it is multifaceted. One thing that we know for certain is that prescription drug monitoring programs, or PDMPs, have demonstrated that they are an effective tool in this fight. So you know what PDMPs are, the electronic databases that hold information about dispensing of controlled substances to patients. These are available in just about every state now. Some states have had them for decades. Others have just recently come online. We are at a critical moment in the evolution of these systems where we have an opportunity to really realize the public health potential of these systems. So I want to talk to you about that today and describe what your role might be in that. So as we look at the prescription drug epidemic, there are a lot of statistics that are counted, a lot of things we count in terms of harm. We look at overdose deaths and just overdoses, but we know that the harms go well beyond that. For patients who are struggling with this disease, there are physical, mental, emotional, and economic harms. Those of you who are on the front line are challenged every day to help reduce these harms, but also ensure that patients have access to needed pain therapy. You are indeed in between a rock and a hard place. You also have a number of demands on your time. Specific to pain management, you are charged with providing these therapies, including assessing the patient's need for them and insurance coverage of these services. Once you provide this care, you must then assess how it's working. Is the patient experiencing pain relief, or are they having side effects? And then importantly, you need to monitor for inappropriate use as well as the development of substance use disorders. And of course, you have to do all of it and a lot more in the confines of a time-limited patient encounter. So there are a lot of statistics when we talk about prescription drug abuse. I want to boil that down to just 3 numbers for our discussion today: 21, 20, and 91. 21, that's the average duration of a patient care visit in this country. 20, every 20 minutes a patient dies from an overdose of prescription drugs. And 91, for those patients who survive an overdose death, 91% of them receive another prescription for an opioid. So the challenge for us is, how can we, in this time-limited environment, ensure that we are providing the best care for patients and protecting them from harm? In an ideal system, we would have an integrated medical record, and that information would help us best identify these patients who are most at risk. Unfortunately, we're not quite there yet. But we do have PDMPs, and these systems can be a valuable tool by sharing with you information about the patient's overall exposure to these medications, regardless of whether they are seeing multiple providers. As such, they are a valuable tool to help us in our efforts. So despite the fact that we know these tools are useful, they are unfortunately not well utilized at this point in time. So this map shows prescriber enrollment to use the PDMP as a percentage of DEA-enrolled, DEA-registered prescribers in each state. Now, this data is from 2014, but you'll see then that only 6 states met the threshold of having 80% of their prescribers enrolled. The rest of the states fell below that, and many of them fell well beyond that, well below that. So we have a need to do more for our patients in this area to better protect them. In order to increase prescriber enrollment and use of PDMPs, a number of states in recent years have taken steps, including requiring the use of PDMPs under certain circumstances, such as when you write an initial prescription for an opioid. So these requirements, that are frequently called mandates, can be helpful. But requiring you to use the PDMP does not mean that you are able to use it well. This next image should look familiar to most, hopefully all of you, who are engaged in writing controlled substance prescriptions. This is an example of a patient's PDMP profile. It's challenging to look at, right? It's complicated. Even from the distance, if you weren't at the distance from your seats, you'd still find it complicated. Can you tell me quickly whether or not this patient is receiving both an opioid and a benzodiazepine, a combination of drugs that increases the risk for overdose? How about medication supply? Do they have doses left from the prescription that you last issued? Or do they need another prescription? So this format that you're looking at, along with time and workflow barriers, stand in the way of you using what is otherwise a very useful clinical tool. So how do we take PDMP use from what is either a professional or legal, in some states, requirement to an opportunity to better provide patient care? We need a better toolbox. So we have an obligation to increase prescriber use of PDMPs by taking steps that remove the barriers to their use. We also need to figure out what information is most useful to patients in these systems, or to providers in these systems to take care of their patients. So there's been a lot of innovation in this space in recent years, and I'm going to go over just a few examples with you. The first are unsolicited reports, and a number of states are already doing these, so you may be familiar with them. So with unsolicited reports, the PDMP will proactively send you a communication when the data in the system indicates that a patient may be at risk for harm. So these alerts are especially useful in situations where a patient may be seeing multiple providers, and it can alert you to the potential for harm. This next innovation, prescriber set thresholds, are a variation of unsolicited reports. And this is an opportunity for you to set your own threshold for when you want to be notified, to not wait for when the state wants to send you a notification. And so these thresholds can be very useful, say, if you enter into a pain management agreement with a patient. In those instances, you can set the prescriber's threshold at +1. So if that patient breaks the agreement by seeing other providers, you will be notified. You know, and I would point out that the prescriber set thresholds are not an opportunity to get rid of patients that you're concerned about, or that scare you, or provide a challenge in managing, but rather this notification should serve as an opportunity for you to have a dialogue with those patients, which may be a challenging dialogue, but to find out whether or not their pain management therapy is currently working, or to determine if they need a referral to a pain management specialist, or if perhaps they're heading towards substance use disorder and need an intervention. So the last innovation that I want to talk about today is the inclusion of other information in the PDMP beyond prescription data. We see a number of states that are taking efforts to do this. And one example of this is the inclusion of overdose event data within the PDMP. So in this instance, if a patient has an overdose event and is thankfully resuscitated and survives that event, likely through the use of naloxone, that information is provided to the PDMP and available to you. So in those instances, you can see a patient who has already had a harm associated with the use of these drugs. And again, that's just an opportunity for you to look at how can I better manage care for these patients? What safeguards can I put into place to ensure that these harms do not recur? So these are just a few of the innovations that we see across the country. There are more out there, and there are more to come. So I started my presentation today talking about time. And undoubtedly, as we look to implement these innovations, it is likely that the time you need to provide care to these patients will initially increase, because we need to take steps to put these innovations within our current patient care process. But over time, these innovations represent an opportunity to not only decrease time once we're accustomed to the processes, but also to use that time more effectively to prevent patient harm. So as thought leaders in your field, I'd like to leave you with a couple thoughts today. Please take the perspectives that you're hearing from myself and the other panelists, take them back to your colleagues and discuss what you can do in terms of addressing this epidemic. Specifically related to the PDMP, within your practices, look to see, are you using best practices for accessing and applying the information in these databases? And if you're already applying those innovations, are there opportunities for improvement? And then importantly, provide feedback. There is always an opportunity to provide information to your states about what you need and what works better and what will allow you to better provide patient care. And I encourage you to take those opportunities. Together, we have an opportunity to unlock the potential of these databases to both increase patient safety and improve patient care and public health. Won't you please take this challenge with me? Thank you.